Today we're going to start our chapter 16, the breasts, and just like the thyroid, we have quite a few weeks that we can kind of work on this. So it should be, um, I'm going to split it into three, so there's not going to be so much information at once. So it should be pretty good little section. So I think a lot of us are kind of a little bit familiar with mammography and its role in imaging the breast. Usually around after 40 years of age, they like you to do an annual um, mammo to detect any kind of cancer or suspicion or anything like that. Sonography, though, its role is it really differentiates cystic and solid. It doesn't have any kind of radiation. So if a patient is younger and has a breast mass, they usually like to start with sonography instead of just going straight to mammo because they don't really want to radiate the breast unless they have to. It examines the patient without minimal painful compression. Like with mammography, your breast is compressed. So it can be kind of, um, you know, uncomfortable. And it also is used for guidance for procedures. And like if a patient has a mass, um, sonography usually does like a breast guided biopsy or an ultrasound guided biopsy of the breast to take some tissue to check to see if it's cancer. The limitations are operator and equipment dependent. More seasoned techs can find more stuff than a person that is just starting out. Microcalcifications are not as easily seen as on mammo, and some masses with similar benign and malignant characteristics. So this is an indication for a breast sonography. A lot of the times they will, if they see something on mammography and they're not sure if it's cystic or solid, they'll order an ultrasound of that area so we can decide if it's like a cyst or solid or yeah, it gives a different kind of imaging. The anatomy of the um, breast is kind of interesting. They're mammary glands. They're paired dome-shaped anterior chest wall structures. You have the skin, nipple, and areola area. The Montgomery glands of the nipple secrete oily substance. Female breast primarily composed of glandular, fatty, and fibrous connective tissue. Glandular elements primarily produce and transport milk. And the stromal elements are like fat, fibrous connective, blood vessels, lymphatics, and nerves. Posterior to the breast, there's the pectoral muscle. This is an image. So the breast is divided into by fascial planes into three layers. So there's a subcutaneous fat layer. There's the mammary or parenchymal. That's where all of the little ducts are that carry the milk and contains functional glandular elements. Radial placement around the nipple, which we'll talk about in just a little bit, contains 20 to 40 ductal lobular units. This is where the cancer usually is in these ducts. And during pregnancy, become milk producing acini. And small segmental ducts join to form main lactophorus ducts that enlarge at the nipple. It's pretty amazing. And then you have the retromammary layer. So you have those three layers. So, like I said, the terminal ductal lobular units is the location of most benign and malignant disease. So, and that's where my mother had cancer, breast cancer, and that's where hers was too. Um, Glandular tissue is the largest area in the upper outer quadrant. And then there's the breast, the Cooper ligaments that support the breast. I also have, there also is some vascularity in the breast. There's arterial branches that help feed, and then venous. Here's like the terminal ductal lobular unit. And there's quite a few of these, and this is where the little cancer likes to go. But this is also where the milk is produced. So, you know, you gotta have it. There's also a lot of lymph around the breast, and it originates from the connective tissue near the lactophorus ducts and communicates with the subareolar plexus. The lymph drains into nodes and follows venous pathways. If there is cancer, they always like to look at the nodes because it's pretty easy for the cancer to spread into the lymph. The majority of the lymph drains into the axillary nodes and the lesser drainage into the mammary lymph nodes, the interpectoral lobes, and the supraclavicle nodes. So these are just some classifications of the axillary lymph nodes. You do not need to know these. So the sonographic anatomy, this is what we really want to focus our attention on, is the skin layer is two thin reflective bands encasing a medium level echo. So that's going to be your skin layer. The thickness should be 2 millimeters or less. If it's greater, it could be neoplastic, traumatic, post irradiation, or inflammatory changes. I know with my mom, she had radiation in that area, and that part of her breast is a lot thicker in skin from, the radiation. So she would probably have a thicker area than 2 millimeters. The nipple is homogeneous texture. It's difficult to look underneath the nipple because of the shadowing. But probe compression and the use of ample scanning gel will flatten the nipple and reduce trapped air pockets. Transducer angulation, spatial compound imaging. There's different techniques that you can use to see underneath the nipple, but if you're just looking at it, it's going to shadow. The pre-mammary layer, the subcutaneous fat layer, is between the skin and the mammary layer and does not extend beneath the nipple. Its echogenicity of fat will be mid-level and gray and easily compressed. And there's Cooper's ligaments there. The mammary layer, that's the part that is where you really like to focus your attention on. It's enclosed between the anterior and posterior mammary fascia. It has the greatest variation echo pattern because if you have fatty breasts, it's going to look a different way. If you have more dense breasts, it's going to look more hypoechoic. And you can see ducts, and they should measure 2 millimeters or less. And there's the retromammary layer, contains small fat lobulars and some suspensory ligaments, and it's thinner than the subcutaneous level. You'll see the chest wall and ribs, lymph nodes. You can see in the axillary, they should be less than 1 centimeter if they're in the mammary area. Okay, so now that I said that, you can kind of see So the skin is this reflective area. Then you have the pre-mammary zone, the mammary zone here, and the retromammary zone. And a lot of the times, if there is something, it's going to be in like the pre-mammary or the mammary zone. In the mammary zone, you're going to see little ducts, and that's normal. This can look like a mass, but it's not a mass, it's a rib. So a lot of the times, the other thing that I do is I make sure that I'm turning long on whatever I'm looking at to see what it looks like. Because if you're just looking transverse, you could be like, well, is this like a retromammary mass? But it's actually the rib when turned on it. This is a lymph node. The amounts of stromal and glandular tissue in the female breast depends on the age, parity, administration, pregnancy, lactation, or obesity. Young female breasts are usually densely glandular, but with age and pregnancies, fatty replacement begins. This is a mass in the mammary layer. The breast development begins in utero along with bilateral ectodermal milk lines. And developmental anomalies are uncommon. But here are some of the things that can happen with that. In comparison to fat, what is the echogenicity of the stromal fibrous tissue? And it's hyperechoic. Which breast layer is imaged immediately superficial to the chest wall? Superficial. And that's the retromammary layer. And which are considered a functional unit of the mammary layer? And that's the terminal ductal lobular unit. And that's the part where you got to be careful with the cancer. We'll go over this really quick and then we'll be done. So prior to scanning, it's so important, just like anything else, but even more important in breast, I think, because you got to really know where you're looking at. You review previous images, clinical history, location of palpable mass, biopsy scars, or breast changes. So a lot of the times when you're doing a breast ultrasound, you can ask the patient and they can kind of fill the younger patients. Now, if you're doing like a diagnostic ultrasound where they had a mammogram first and they saw something and then you're going to, usually the mammotech will like talk you through where it is. So then you have an idea. So with the transducer, you're going to use a high resolution real-time linear array, 12 megahertz or higher. So basically your small part probe. And the grayscale settings, all tissues should be demonstrated from the skin to the chest wall. Breast fat should have the same echogenicity throughout the breast layers. So make sure your TGCs are correct. So patient positioning, you minimize the thickness of the portion of the breast being examined. Usually this means I usually roll the patient 30 to 45 degrees towards me if I'm like, depending on the breast, or away depending on which breast you're looking at, to like minimize and flatten out the breast. The other thing I do is I have them raise their arm so you can see like the axilla area. And then that'll kind of help the breast become more flat. But if there is like a palpable mass, a lot of times, whenever they can feel it, like depending on if they're laying flat or laying a different way, that's the way that you want to scan. So there's different kind of techniques. You could do like a whole breast. A patient just is having breast pain, a younger patient, and you'll just scan through the whole breast to see um if you see anything. And I do like every couple of centimeters, yeah, I'll take another image. So increased pressure flattens the Cooper ligaments and eliminates false acoustic shadowing. So you want to make sure that you're putting some pressure, not too much, but some pressure to kind of get rid of the acoustic shadowing and get rid of something that could be potentially look like a mass. Key lesions are documented with or without calipers. The maximal dimension is recorded. You do a 3 different plane measurement too. Different people have different ways of imaging. So that'll kind of depend, like annotation. So that'll kind of depend on um, where you are. But how I usually did it was I do like right breast, and then I'll show you the clock that we use. Right breast, 2 o'clock, 5 centimeters away from nipple, or 4. Or so there is some kind of like, okay, exactly where it is. And there's other methods, like depth or distance from nipple. So this is what we're kind of talking about with the breast. You use a clock. So on the right breast, as you can kind of visualize, just like clock, 12 o'clock would be straight up, 3 o'clock would be to the left, 6 o'clock is straight down, and 9 o'clock. On the left breast, it's going to be the same thing. And then the other thing that you do is we do rad and anti-rad, not sagittal and transverse. The difference is radial, it's like the sun, basically. You're kind of like a clock. Um, the hand is going around like a clock, and that's radial. And anti-radial is the opposite of radial, basically. So you're kind of looking at it more in an array than sagittal and transverse. You can also do the 1, 2, 3 ABC method, but a lot of people just decide to do it from a distance from the nipple. So how many centimeters away? So I would look at my probe and see like that's like 4 centimeters away. So I would kind of use that as a measuring stick when finding that mass. This is a nasty picture of a cancer, which we'll talk about. It just looks ugly. Standard mammographic projections, you're going to have, there's a couple different images that they take: a craniocaudal image, which the x-ray tube is oriented vertically over the breast, and a medial lateral oblique, where the breast is in profile from the axilla, and a 45-degree x-ray beam is passed through. So these are the images like of a craniocaudal and an MLO. And from those, the radiologist looks at it and can decide if he sees anything. These are the American College of Radiology ultrasounds assessment categories. So if he looks at mine, it's native, routine. Those you just get them every year. So if there is a probably benign, like they see something on ultrasound or radiology or on mammo, and then we scan and it looks cystic and just like a breast cyst, it's probably benign. It's greater than 0%, but less than 2%. They'll do like a 6-month follow-up. So, and then suspicious, low suspicion, moderate suspicion. If it's suspicious, then they do a biopsy. If it's highly suggestive of a malignancy, they do a biopsy. And then they do surgical excision if needed. So these are like the different kinds of masses. Which we'll talk about in a little bit. Okay, so this is an interesting one. Where will a mass be visualized in the medial breast on a medial lateral oblique mammogram view on the sonogram? So if it's on the medial breast on an MLO, I think let's see what they say. Superior. Yeah, I'm not sure on that one. I'm not very good at reading mammograms. That's why you need your mammo tech to help you. Or if you're like become a breast sonographer, then you will know how to do this. Which transducer is recommended for breast imaging? Oh, I know this one, I think. It's a high frequency. Yes. All right. So we'll get into breast disease next week, and then we'll do malignant breast the week afterwards. So all right, have a good week.